New York. Mandarin.
Hi.
Hi.
Sorry for the technical today I'm going to present about Mallory-Weiss syndrome. So let's just see what is Mallory-Weiss syndrome. So this is what a Mallory-Weiss syndrome looks like. Longitudinal tear in the mucosa there at the junction of the esophageal junction, or the junction between the stomach and the esophagus. What is Mallory-Weiss syndrome? Let's zoom into what is Mallory-Weiss syndrome. Let's check it out. So Mallory-Weiss syndrome is which was first diagnosed by Mallory Weiss in 1929 when he saw a patient after an alcoholic binge started vomiting blood. He started having hematemesis. So then, according to his theory and his observation, we got to know Mallory-Weiss syndrome. So what are the epidemiologies of Mallory-Weiss syndrome? So in recent years, we have started seeing more and more patients with Mallory-Weiss syndrome, and it's prevalent between the age 47 to 116 people per 100,000, especially in patients who have predisposition to ulcer or already have ulcer disease in their anamnesis. But the age range for Mallory-Weiss is quite high. It's quite over a detailed age range, but mostly found in the age range of 40 to 50. 15% of all episodes causes hematemesis, but in most of the cases, or in the rest of the cases, it may not cause hematemesis, but internal bleeding are seen. Tears can also occur in children, but it's less common. So this is how it looks like. Can't see from me, but it's good. When we have an internal gastric bleeding or upper gastric bleeding due to Mallory-Weiss here. So in this tab, we can see cause, presentation, differential diagnosis, investigation. Let's see more into causes. What are the basic causes for Mallory-Weiss syndrome? Alcoholism, aspirin ingestion. As we all know, aspirin, apart from being an anti-inflammatory, also has anticoagulant effect. So when a person is on high doses of aspirin, it may happen that blood coagulation system or blood coagulation is impaired, and accidental bleeding can stop. Hiatus hernia, projecting hernia is also a predisposing factor. Retching or vomiting. When a person is under intense retching, or a person is committing intense retching, vomiting, then the pressure gradient in the abdomen is higher than the pressure in thorax. So we have a negative pressure gradient in the thorax and a high pressure gradient in the abdomen, which causes a pressure imbalance, and longitudinal tear takes place. Other predisposition factor would be hiccups, intense hiccup, coughing, blunt abdominal trauma, and cardiopulmonary resuscitation. When you're doing CPR on a patient, maximum stress or pressure is exerted over the sternum, and it's radiated downwards toward the xiphoid and down the stomach, so which is very, very likely that there might be cause there. Other gastrointestinal disease for gastroenteritis, gastric outlet obstruction, malnutrition, vulvaritis. So here, it can be fixed. Hyperemesis breviterium, hepatitis, biliary disease like gallstone and cholecystitis, especially obliterative gallstones, when the gallstone is too big for the biliary duct, and it may actually rupture. Renal disease, vomiting is often associated with renal disease. We know that in case of chronic renal failure, in case of pyelonephritis. So in these cases, the patient is under intense vomiting, and that increases the intra-abdominal pressure, causing a predisposition to Mallory-Weiss tear. In vomiting, particularly in children in case of encephalopathies. Cyclic vomiting syndrome, as we have read in India. Other causes include drugs, severe diabetic ketoacidosis. Iatrogenic tears are common, even with high incidence of retching during endoscopy. When a person is undergoing endoscopy, it's highly normal. It's very normal that the person will have gag reflex. So due to gag reflex, the person will retch, and that may cause a Mallory-based tear. And apart from these, like apart from the all above mentioned causes, Mallory-based tear can also be caused due to idiopathic factor. There is no known reason why it actually caused. Now let's see in the presentation part how it's presented in patients. The classic presentation is hematemesis, I've already told you. Like around 85% patients who have Mallory-based tear will have hematemesis. The rest of the person may not have it, with slight or minimal bleeding, but bleeding present nevertheless. Other symptoms will include melena, lightheadedness, dizziness, and syncope. Of course, if we have any hemorrhage, so due to lower blood pressure, these are very common symptoms. Abdominal pain. If we have a distension of abdomen due to collection of the blood inside the abdominal cavity, we have distension and expansion, so the stretch receptors will be activated, and we should have pain. Examination. How to examine the patient when he comes to the clinic to rather diagnose or think about Mallory-based tear. So there are no specific physical signs for Mallory-based tear.
You can hear. No pain.
There are no very specific signs that will give you a telltale symptom that this patient has Mallory-based tear. Degree of blood loss. We all know that there are three degrees of blood loss, fourth level of blood loss. So we can assess the patient's condition according to the level of hemorrhage. The Rock-All scoring system can be used. Well, when we have a prognosis of 8, which is extremely good, so the patient has an extremely satisfactory condition. But if the Rock-All score goes below 3, which is very bad prognosis. When we have Mallory-based tear, the prognosis is generally, the score is generally or less. Now the differential diagnosis. What kind of differential diagnosis can be associated with Mallory-based tear? Bleeding, esophageal varices, gastritis, esophagitis, Borhage syndrome, stomach cancer, ulcer, gastroenteritis, peptic ulcer disease. Now, investigation. Endoscopy, of course, right? The first method of investigation, first choice investigation for Mallory-based is endoscopy. This is a picture of what it looks like when the patient undergoes an endoscopic investigation. Other diagnostic minimum shall include CBC, coagulation studies in platelet counts, urine analysis, RF, urea, creatinine, electrolytes, ECG, and cardiac enzymes. Cardiac enzymes is chosen in order to rule out cardiac myopathies or cardiac-related complications. For example, high level of troponin. Imaging studies, chest X-ray, erect and supine abdominal X-ray, CT scan, and ultrasound. All of them will be helpful to diagnose Mallory-based tear, but the most effective and the most visible and convenient, I would say, is endoscopic method. Now in this segment, we're going to talk about treatment, complication, prognosis, and prevention. So for treatment, what should be the first choice of treatment? Resuscitation and initial management. When the person is under hemorrhagic shock, when the person is having intense hemorrhage, the first order of treatment is resuscitation and volume replacement, either by plasma replacement or by corpuscle replacement, the blood component, replacing the blood component. Maintaining airway, provide high flow oxygen, correct the fluid losses, electrolyte loss. Then initial fluid resuscitation, maybe with crystalloids or colloids. Give intravenous blood transfusion when 30% of the circulating volume is lost. So when we have a second degree of hemorrhage, we can go for transfusion therapy. Endoscopy, which is ideally the best treatment that you can provide for Mallory-based tear, should be performed within 24 hours. Like the first occurrence of the tear, and within 24 hours of its occurrence, endoscopy should be performed. Proton pump inhibitors is not recommended prior to endoscopic investigation and the endoscopic treatment. Most patients with 80%, more than 80% present with a single tear. And the tear is usually just below the gastroesophageal junction and the lesser curvature of the stomach. But the other, sorry, the other, other than the other than the in-person people, they go with more than one tears, and that will involve multiple intervention methods. This is how it looks like when it undergoes an endoscopic surgery. So what are the complications that might be associated? Vomiting, hypokalemia, and other metabolic disturbances. Aspiration pneumonia, if you aspirate the blood. Perforation and mediastinitis. Internal bleeding also. Comorbidities, myocardial ischemia, precipitating, for example, myocardial infarctions. Hepatitis, liver failure, renal disorders, and diabetes. Prognosis. What is the prognosis for this kind of patients? It's generally it's excellent. It's usually resolved by endoscopic method. No further open surgical intervention is generally required unless the tear is massive. Spontaneous and the tear heals rapidly. Sometimes you don't even need to go for a surgical intervention sometimes. Usually within 48 to 72 hours. Prevention. How to prevent malarial-based tear. Recurrence is rare. Once you have malarial base and it has been treated successfully by the doctor, recurrence is rare, but we suggest the patient not to go for alcoholic beverage, straining, lifting, violent coughing, anything that might increase the intra-abdominal pressure and may lead to secondary pressure on the weakened area, already weakened area. And because if it recurs, it is generally hazardous because in this case, the tear will be longer, bigger, and more intense and deeper. So there will be more hemorrhage. So if you had a second degree hemorrhage in the first case, probably this time you'll have a third degree hemorrhage. So thank you so much. That was my
Часом буває так, що хочеш почути речі, яких ніколи б не знати, і тягне за руку тебе в то місце.